thank you, Michael, for that introduction. I think what you can see from who's in the room this morning, that as we try to improve access to care for palliative care patients, what we've really done in this project is combine the issue of call centers or nurse lines with hospice palliative care. And for me, this has been a real learning. Velda is very accomplished and understands a lot about nurse lines and call centers, but for me this was really a big learning curve. And so one of the things that you learn whenever you move into a new area, that words have very important meaning that you may not realize. So if I'm saying something incorrectly, I apologize right now. It's just like people who have to learn in terms of the hospice palliative care field. Words have lots of meaning in our field, and we get all upset about if someone gets it wrong. So it is a joint learning. And really what we want to do this morning, I think, is through the case studies that you're going to hear from Della and Diane, kind of give you more chance to specifically understand how we went about the process and how it's working in BC. So what I want to do is just talk about the background about why we think that we need telenursing to support patients at home. And the background around how a group of us worked with Pallium to develop what we're calling a prototype resource for other jurisdictions in Western Canada. And then we're going to break, and Della and Diane are going to go through sort of the nuts and bolts of how it works and do a case study. And then following that, we're going to I'm going to come back and talk a little bit about future development and the resources, the written resources that we've developed, and then we're going to have a break, and then we'll go into really questions and answers. So maybe for this first part of the morning, if you can kind of write down your questions, and then we can move through the facts, and then we'll have really the rest of the morning really for dialogue and talking about moving forward. So as Michael has indicated, Pallium was a $4.3 million initiative under the Primary Healthcare Transition Fund that went from December '03 to March '06. We started this project really just beginning to talk about it in November of '04. So that's really not very long ago, and we realized there was an ending time, and so we've really had to move very quickly through this project, given that all of us have more than full-time jobs. This was something we were doing really because we were committed to it and for the love of it. So it's been quite a challenge to move quickly, given that the summer was in there. Pallium wants to make a demonstrable and enduring impact on hospice palliative care capacity. And I think the enduring is an important word, because we're talking about a project that will end in March '06, but we really want it to live on in the world of hospice palliative care and continue to support patients. And I think this is a project that really has that potential. It's part of the overall initiatives that occurred for nursing within palliative, and has 3 programming streams: outreach, education, and development, knowledge management, and workplace learning, and service development and system readiness. And it was actually at a service development institute, I think, that a number of us who were involved in management or leadership positions in nursing came together and having lunch, and you know how you always have wonderful ideas over lunch, and we were saying this is still an issue for many of us. The issue of who do our patients call after the home health office closes, after the doctor's office closes. Many of our patients don't have access to enhanced or specialized advice. And we had started a project in Fraser Health, which you're going to hear much more about, but we had received some money in terms of moving our plan forward in Fraser Health with the goal of providing sort of support to our patients after home health office is closed. It's never as much money as you would like, but it was some money, and we were looking and saying, you know, how far can these dollars go? Fraser Health covers about it's 1.5 million. It's the largest health authority in Canada. Covers about a 2-hour driving distance, but has some very rural areas as well as some very urban areas. And it was really Della's thoughts around, you know, I think you should go talk to the Ministry of Health. Can we hook up with the nurse line in BC and see if there's a synergy there? And at her urging, I did that. And you know, timing is everything, because I fully expected to go and meet with Lori Halls and her team and hear, well, that's a nice idea and we'll think about it, and you know, maybe there's a possibility. But by the time I left, and about an hour and a half later, it was, yeah, this is on our radar screen. This has been an identified priority in our province to improve access for palliative care patients, and we're very serious in wanting to partner with Fraser Health, and so that's really where we came from. Pallium consists of palliative care leaders from major universities, health authorities, voluntary sector, and governments. 40 organizations and 300 plus leaders, and I'm sure this slide is old and it must be more than this by now. Primarily active in British Columbia, Alberta, Saskatchewan, Manitoba, Yukon, and Northwest Territories, and Nunavut, with pan-Canadian linkages, understanding that many of the products that I think that are being developed have applicability across Canada. So going back a little bit to why a telenursing project, well, certainly I've talked to you about our passion for improving access, our experience in Fraser Health of the pilot project, which I shared with my colleagues. And after that lunch, I think it was Marie-Josée who is very quick to take a pen to paper and said, I'll write it up and send it off to Michael, and we'll see if this proposal can be supported by Pallium, because while we had done the work in BC, you know yourself, just even the dollars to get people together to meet and plan is something that we often don't have within our own budgets. So we put that forward, and that was accepted. So then we began the task of, you know, looking at the literature, seeing what other projects had happened in Canada and in the world. One of the things that we did know was that the survey that was done in 2004 by the Quality End of Life Care Coalition did note that 50% of respondents indicated that they would use a provincial telephone or telehealth service for information. So there seemed to be a level of acceptability amongst patients and caregivers. We saw that access to some service could reduce unnecessary admission to hospital. Certainly our patients in Fraser Health, as you'll hear in the case study, would largely have to go to an emergency department for any kind of advice or reassurance or management. We wanted to provide increasing support to caregivers. We do want to see the number of patients who are supported to die at home to increase in our health authority, and we certainly can't do that without more support for patients and families. We wanted to be able to assist them with decision making and enhance communication and support between health professionals and family caregivers. We didn't find a lot of literature actually out there in this area. We did find a couple of studies, one from New Zealand, I think, where telephone support had been seen as valuable to meeting rural support needs, specifically in palliative care. So for those of you who, telenursing is the new learning for you. I'll just review sort of a bit of the state of the nation. Really not a long history. If we look back to the first call centers established in 1994 only, so that's really 11 years ago, going up to 2003. As you know, staffed primarily by registered nurses, some links to pharmacists sometimes, offer consultation in the management of specific symptoms or health problems, referral to other services, and health information. Advice is given according to medically approved protocols, and it's available in many languages and for the hearing impaired. And if we were to compare that to what happens in some of our jurisdictions, not all, but in Fraser Health, for example, we tended to have perhaps informal links for patients via the phone. It was often giving the patients a phone number to phone into a unit that was a palliative care unit, and you know, a nurse, if they're not, I mean, how busy would the nurse be when they answered that phone? What kind of advice were they giving? How did we document that advice? What follow-up there was? Pretty informal and not something you felt really very comfortable about the quality of that advice, and also the pressure on the nurse who was having to take that call. So I put this picture in here. It's a picture that Velda allowed me to use. when she was touring the province in northern Saskatchewan for the nurse line in her province. This is a woman who had a fungating breast lesion. Certainly was a long way away from being able to see a primary care provider, but Velda really knows, has a phone. So she could access that phone for advice. So why telenursing? Well, health authorities certainly struggle with the cost and logistics of 24/7 care. And I can say in our health authority, even though we got some new dollars, we actually we're really facing very significant human resource shortages. So we have positions that are unfilled in home care simply because there aren't the people out there. So it's a matter of dollars, but it's increasingly, as I know you all are aware, we are going to face a very significant challenge around staffing. And that's only, as those of you who've been at the Palliative Care Conference the last few days understand, it's only going to get worse. So telenursing offers access to a nursing workforce 24/7. The nurses are generalists who deal with a broad range of health problems, and the nurses can become virtual members of our healthcare teams. They also, certainly one thing that I think was very impressive for us in BC is the ability to document responses, to look at, in our case, to see where the calls were coming from, which community was calling in, and what were the specific issues. It really gave us information that we didn't have within our own health authority about the problems that patients were facing overnight. So our original purpose was to develop a set of peer-reviewed telenursing protocols, which were following the CHPCA model, which is the Canadian Hospice Palliative Care norms. We had a pretty short timeline, and Pallium paid to bring us together. And then certainly those of us working in palliative care programs and cancer agencies gave of our time. These are the members of the committee. And we did one presentation to the multi-jurisdictional committee, and Laurie Halls and Diane McCormick were our link to that group because they have been involved in British Columbia. So some core assumptions that I think flowed out of certainly our experience in British Columbia, that we need to really be grounded in the practice reality, like what's really going to work. And an example might be the link back to Fraser Health couldn't be to 10 communities and 10 different fax numbers. It needed to go to one place, and then it was our problem to get it out from there, because that was the practice reality in the call center. Both sides, I think, from the call center side and from the health authority region or jurisdiction, have to be ready. It augments current resources for enhancing community care, but does not replace them. And this is one of the things that you're going to hear about later on, that really was our learning. This isn't about allowing health authorities to say, well, that's it for palliative care now, we don't need to provide services. So we're going to be hopefully reinforcing that message. It's competency-based and evidence-informed. And it is dependent on the implementation of standardized protocols, which we have developed and put in the project toolkit, and you've got the draft in front of you there. So this has been an evolution of an idea, and I think at the beginning we may have thought that this meant that we had to start with a blank page and say, well, if the symptom is pain, how do we manage that for palliative care patients? That's traditionally how we would do it if we were developing a nursing protocol or a medical protocol, but that's not the case here. And we're going to talk about how we build on what's in the existing database of the call center. It would not work for unknown callers, and this is for those of you in the palliative care side. This is an important thing to understand, and I think it was a learning that we had to go through. This wasn't about sort of general information for palliative care patients. Not that that isn't already provided in the call centers. So if a patient may be phoning in and saying, well, I'm wondering what the resource is for, you know, cancer advice or the ALS Society, or I have this or that, that information exists already in call centers. But being able to move a patient to the next level of advice does depend on knowing that the patient has been identified by someone as palliative, and we're going to talk about that a little more. So to really improve care, to make a change in what would happen, what would prevent that patient from coming in to emerge, they needed to be known and then to have the link back. So there's the being known and then having some sort of a link back to the community. Otherwise the patient is left, and we don't want that to happen. I think we have to remember that this is nursing advice that's given, and it had to be within those well-defined and articulated standards. And we've done some preliminary trying to understand how we could use what we've, from a technological point, put into the nurse line into other systems which are different, and there is a sense that this is technologically doable. So the assumptions, and this is more certainly for those of you in the palliative care world, the decision support software that's used in nurse call centers is different. It has a different name in various provinces, but basically they all use standard and widely accepted, medically approved protocols. They flow from the idea of symptom triage. The disposition is based on a widely accepted timeframes that are similar in all provinces. And again, the protocols do not need to be developed from scratch, but are enhanced for the palliative care population. And so I'm going to let Della and Diana go ahead with